Kia ora koutou, and no mai haere mai to our first webinar of our diabetes course. Thank you all for joining from across the motu. It's fantastic to see the breadth of the country covered. And just to introduce myself, this is an honour and privilege to bring this course to you. Ko Ryan Paul Takuingoa, ko Ngāti Maru Te Iwi, no Kirikiri Roa aho. So I'm an endocrinologist from Hamilton, and I'd like to introduce the rest of the team. And to start off with, we're going to have the person you probably had the most to deal with, and that's Salita. And then Salita will hand over to Brian, who's my right-hand man and helping bring this course. So Salita, able to introduce yourself now.
Kia ora, everybody. E te puakia hau ki te rohi o Hauraki Engari no Ingarangi Airana ko te rana tine maka o ku tipuna e hununga a hau ki te awa o te koiranga me te maunga o te kai tarakihi e tuhunga nehi haumanu ma te hoka a hau ko Salita tuku ingoa no reira tēnā koutou, tēnā koutou, tēnā koutou katoa. So kia ora, I'm Salita. I'm a diabetes nurse specialist and I do a lot of the admin behind the scenes. So if things aren't working, do please let me know. And I will be helping throughout the course. So I'll often be on here on Monday nights facilitating with Ryan, and either myself or Brian will be facilitating the Thursday sessions. And then in mentoring, you will see a lot more of Brian and I throughout, and Ryan will likely be facilitating a lot of the Thursday sessions with our guest presenters. I'll hand over to Brian. You there, Brian? Maybe not. We might
That's
have
okay. That's right. Brian introduced himself at some stage.
I'll ask him to unmute.
Thanks, Salita. Salita does do a lot of the hard work, and a big thank you to her to getting us off the ground. But we might as well get stuck into our first webinar. The first thing I'll say is a big mihi to all our sponsors. We could not bring this course to you for free. Making sure it's free is really dear to our hearts. We want everyone to join as much as possible. And so we've got over 1,300 people this year, which is absolutely fantastic. And we're pretty much at capacity tonight. So well done for getting those that came early. Just a wee bit of housekeeping. Please stay on mute the whole time, but please feel free to ask any questions that you want. And you can put that in the Q&A function or the chat, and we'll come to that at the end. And I think Salita's already sent around a quick message about upvoting those questions that you want to answer first, and we'll come to those. Obviously, confidentiality is a must, and that becomes more important as we head towards the mentoring and case discussion sessions. And the one thing is just we're all here to learn. Please respect one another. Every day is a school day when it comes to diabetes, and that's our sort of take-home message. So just a brief outline of what the course involves. So this is our first webinar. There are 8 webinars in total. They're held every week, but we will have a 1-week break over that King's birthday week, just so everyone can have a holiday. That will be the same session on Monday evenings and Thursday afternoons. So there's no point in watching both unless you're really keen. But just to let you know, we're going to take the Monday evening a little bit slower because people do have more time. There is a Thursday, so because everyone's time poor at work, it'll be a lot sharper and to the point. There will be the recording available at any stage, should you choose to watch that right through the whole course. And just after the webinar, if you can make sure that you do your attendance, that's important for certificate purposes. And there will be 2 multiple choice questions for each webinar. I promise you, if you watch the webinar, you will easily get those questions. Please don't stress at all about any questions at all. We then have a short break after webinars. We come back into the mentoring sessions as Salita discussed. They're exactly the same times. Monday evenings will predominantly be case-based discussions that Brian will lead and answer questions. Whereas Thursday sessions, I'll be involved with guest speakers from all disciplines involved in diabetes care, and hopefully you'll find those really useful learning experiences. They will be different on Mondays and Thursdays, so you are able to watch all 16 if you wish, but you only need to do 8 for certificate purposes. And if you do basically every each of those sessions, you then get the certificate of completion and the CME certificate. We've got the college and the Aotearoa College of Nurses accredited. Always keen to try and get more organisations if you let us know if you require that. We're also trying to work hard to make sure we can get some postgraduate certification for this as well, including retrospectively. That is very much still a work in progress. So now we're going to get into our first webinar, and that is really a lot's changed in diabetes care in Aotearoa over the last sort of 5 years, and there's a lot more changes coming. So that's going to be the focus of tonight, including what the new management algorithm for type 2 diabetes, because if you've been in the game for a long time, it has really changed over the past few years, say to 5 to 10 years ago. So I will start off this course as in terms of a preface. So I think we all know that type 2 diabetes is one of the greatest causes of disparities for health. In fact, in Aotearoa, full stop, particularly for our Māori, Pacific, Indian and rural populations. And it is something that we can do something about. It doesn't matter where you are in the world. Clinical inertia in terms of escalating treatment is still the greatest barrier to optimal diabetes care. And I'll be talking about that the whole way along this course. And even through all the struggles that we've had, particularly in primary care, still over 97% of people with diabetes are enrolled in a practice. And we know that at least 90% of these people with diabetes attend the practice at least 2 times a year, and almost 3/4 of those with an HbA1c greater than 75 millimole per mole had pretty much exactly the same HbA1c last year, despite picking up scripts for all their glucose lowering therapies in the meantime. So these are people that are basically doing everything that they've been told to do, and it's about how can we maximise those opportunities of contact to get people to the targets and get them better, to where we want them to be. And just to follow that on, we know that diabetes is the greatest cause of disparities, yet actually if you look at all the factors involved, although socioeconomic factors can be hard to address, we can make big differences as individuals in terms of our prescribing. We know if we normalise all those factors, that actually being Māori Pacific doesn't carry any extra risk. It's about how we can make those differences in providing care that can basically reduce those disparities. So it really is about maximising every opportunity you can. I know that we'll stretch, they may be coming into the practice for other reasons and not their diabetes, but how can we capture that? How can we do what we do? So in terms of just going over some key changes in diabetes management. So in 2021, in February, we got empagliflozin or Jardiance, and that followed 6 months later with dulaglutide or Trulicity. So empagliflozin is an SGLT2 inhibitor, and dulaglutide is a GLP-1 receptor agonist. We then got liraglutide or Victoza, which is in the same family as Trulicity later on, but they are big medications. And I will go over each of these in a lot more detail through the course. But we all know that there was a big shortage of GLP-1 receptor agonists across the world. And then we were, for a long period, unable to start either dulaglutide or liraglutide. Is just to make sure that you know that we can now start liraglutide again for people that haven't previously been on GLP-1 receptor agonists. And that is a very important treatment tool in the armory of diabetes. What's also happened over the last few months is we now have empagliflozin available under the heart failure criteria. What that means is that people with diabetes and heart failure can be on funded empagliflozin for the heart failure, then either funded liraglutide or dulaglutide for their diabetes. So that allows dual empagliflozin instead of GLP-1 therapy, which is really, really important. It provides additive benefits up and above either agent alone. And everyone's trying to steal in terms of other specialties, cardiology, renal, etc., saying that the medications are there. They do have benefits well up and above their glucose levels. And so many people are also now choosing to self-fund SGLT2 inhibitors and GLP-1 receptor agonists. And I'll discuss how you can maximize that access as we go through the course. particularly including adjuncts such as a disability allowance. We've had a lot of success there in the Waikato and across the motu. These are the ways that we can make a difference with the tools that we've got. So I don't want people to assume that self-funding is not an option, because there are many ways to open doors. There has been a big change in the diabetes management algorithm as well. So many of you remember that we based our treatment, or we used to base our treatment algorithm on HbA1c. So we'd start off with lifestyle management. 3 months later, if HbA1c was above target, we're adding metformin. Then 3 months later, if HbA1c is above target, we're adding sulfonylureas, and then so forth until we added insulin. Now that is completely changed, because now we're treating people on what makes them sick, what ends up killing them, it's their cardiovascular and renal disease. So now we're basing that on, do they have any complication burden? Is weight loss desirable? Because we know that with weight loss, we do have the potential to not only improve outcomes, but potentially get remission of diabetes, which is what we all aim for. So I'm going to go through that algorithm in a lot more detail. The other thing that happened at the end of last year was we got continuous glucose monitoring, or CGM, and if you combine that with a pump, insulin pump, you get automated insulin delivery. Now, CGM is the gold standard for monitoring glucose levels. Automated insulin delivery is the gold standard for people who are on insulin. So initially, the funding's only really restricted for those with type 1 diabetes or pancreatic diabetes, also some rare forms of monogenic diabetes. That is how the rest of the world started in terms of getting access to diabetes technology. As we go through, I'll talk about how important CGM is also for our whānau with type 2 diabetes. As part of that, though, I will say that many practices and PHOs are starting to fund CGM themselves. There's also free CGM trials that you can use for whānau. So these are the things that we'll talk about. Once again, how can you access diabetes technology for whānau and yourselves, just to make sure we can make everything as easy as possible and reduce that clinical inertia. Other things to be aware of, actually just from the 1st of May, we had Ryzodeg insulin that's now available. That is actually in Ryzodeg. It only comes as a co-formulation. Unfortunately, it doesn't come individually. That contains degludec, which is actually our first truly long-acting insulin. So Lantus, often we struggle to get that coverage across the whole day. The half-life of degludec is about 25 hours. So all of a sudden you can start seeing that we do have truly full coverage across the whole day. We only have that one formulation at the moment, but there's been a lot change. We lost PEMMIX 30 last year. Novamix 30 is going to go at the end of the year. Next year, we're going to lose Protophane Rapid as well. I will talk you through those insulin changes, but just let you know there's a lot happening in that space at the moment. So we just sort of briefly mentioned about how clinical inertia is the greatest barrier. So what you'll find in this course is just reinforcing our national guidance, which is designed to reduce that inertia. So these, you might find these aspects as new, even though they've been national guidance for the last couple of years. So firstly, we're actually going to start screening from diabetes in high-risk patients from 10 years of age. Now that may sound like scary or overkill, but unfortunately we're seeing a lot more diabetes, both type 1 but particularly type 2 diabetes in our tamariki and rangatahi. That's why we actually need to start screening at a young age. We're no longer waiting to confirm the diagnosis. So, previously you may have waited 3 months to repeat an HbA1c, etc. to confirm the diagnosis. We're now doing it straight away. We know just waiting just leads to lack of treatment and harm. Part of that is so difficult to get appointments at present in practices. So we're trying to act on any abnormal results straight away. We're also now starting lifestyle management and metformin together at diagnosis, and part of the course I'll go through and discuss the rationale for that, as it does make a big difference right from the beginning. And if the HbA1c is significantly elevated, and we'll call anything over 64 millimole per mole as being significantly elevated, we're actually thinking about adding in a second pharmacological agent at diagnosis, as well as lifestyle management and metformin. There's always a possibility to reduce treatment with time, but it's about being aggressive and going early. That gives us our best chance for long-term outcomes and to potentially achieve remission as well. We're also measuring the HbA1c every 3 months until we've reached target. Now, well, for most people, the target HbA1c is less than 53 millimole per mole, or 7% in the old terms. Actually, for some groups, particularly young people or those who are pregnant, we may actually choose to go for less than 48 millimole per mole. At the same token, we may actually relax the target HbA1c. It's still an individualized target, but for those people who are at risk of hypoglycemia or where tight glycemic control is not paramount, we may go for 64, 70 millimole per mole. But for basically at least 90-95% of your people in your practice, you're aiming for less than 53 millimole per mole. Once you've got people to target, then it'll be fine to repeat the HbA1c every 6 months. But we're making sure they stay to target. If they go above target, then we're escalating care. Please feel free to keep those questions coming through, so you will go through them at the end. I know this may raise quite a few points. The other part about the guidance is actually considering insulin early. And that would be if the HbA1c is above 90 millimole per mole at any time. Now, this is not an absolute rule. For example, there'll be times where people are drinking 5 litres of fruit juice a day, or they can make significant changes to their diet, and they may not need insulin. But for others, particularly if they have symptoms of insulin deficiency, such as losing weight or being really thirsty or peeing lots, we want to be introducing insulin early, and we're starting that at weight-based. And I'll talk you through, particularly in our insulin webinar, how you can do that safely and effectively right from day one when you're starting insulin. The other thing which is new is basically we're adding in prandial or mealtime insulin as soon as you reach dose of basal insulin more than 0.5 units per kilogram per day if the HbA1c is still above target. Now, for example, what that would mean is if you're on 100, if you weigh 100 kilograms, as soon as you hit 50 units of Lantus, that is your stopping point, your checkpoint for saying, I need to introduce prandial insulin now if they're still above target. Now, we still see people on whopping doses of Lantus, and for most people, that doesn't actually improve their glucose levels at all, but it does lead to weight gain. And most of our whānau with diabetes can't afford to gain more weight. And that's the reason why we're introducing in prandial insulin early. In fact, for most people, we need to introduce it earlier than 0.5 units per kilogram, but that's just a checkpoint, just to think strongly, what do I need to change here? Another thing that we have found is that often, diabetes end reviews were done well, but there was no actions taken on any abnormal findings. And what that meant is that the person didn't get any benefit out of it. It was sometimes seen as a bit of a tick box procedure for funding. What we're trying to move towards, if you find, anything that needs treatment, we're treating. We're acting on anything that needs to. Part of that, and we'll go through the gold standard care or best practice for who should be involved in diabetes care as we go along the course. But it's thinking about, do we need to involve dietitians, psychology, Kaiwhina, Kamanaki, etc. Who's best placed in the team to get the results that we need to. So now I'm going to go through more, thinking about that complication and weight-centric algorithm and the rationale behind it. So really the key point is at least 2/3 of your people with type 2 diabetes will die from cardiovascular disease. Now, as sort of mentioned before, what we know from the PREDICT calculator, that's the main cardiovascular risk calculator that you use, that when we look at, our groups that have the highest disparities, particularly Māori and Pacific peoples, we know that actually it's not ethnicity that's the risk factor, it's all those modifiable risk factors that sit with it. And it's not just cardiovascular disease, it's also renal disease, it's also the sequelae of obesity, particularly clinical obesity, which leads to people getting sick. That's what's the cause of death. So it makes sense we're treating that, we're not necessarily treating just glucose levels themselves. So what you'll find is that the medications we're now using at the start of diabetes treatment are those medications that improve cardiovascular and renal disease up and above the effects on glucose levels, but also the same medications which aid weight loss, which is fantastic for most of our people with type 2 diabetes, but also medications that do not cause hypoglycemia or low glucose levels alone. If there's one thing I want you to remember from this course, it is only insulin and sulfonylureas, so glipizide and glycoside, that will cause low glucose levels. Metformin, Jardiance, Trulicity, Victoza, pioglitazone, acarbose, they will not cause low glucose levels by themselves. It's just insulin and sulfonylureas. Now, when we look at the I guess our medical targets for weight loss, we're not talking about societal targets here, and I think that's a really important distinction. We can talk more about that as the course goes along. But even 5% of total body weight loss will lead to a significant improvement in glucose levels, blood pressure, and lipid levels. So if people do weigh 150 kilograms, for example, if you can get them down, just that 7.5 kilograms, that will lead to a significant difference. It doesn't have to be down to 90, 80 kilograms. It does seem, though, if you want to get remission of type 2 diabetes, that you're probably looking at least 10 to 15% of total body weight loss. Once again, that is not necessarily societal targets, and it is also something that is achievable with the new tools that we have as well. And I'll talk more about that too. Our tried and true medications, our sulfonylureas, insulin, are still important, but the reason why they have moved right down the pecking order or ladder of treatment is not only do they potentially cause low glucose levels, but they are the medications which can also lead to weight gain, particularly insulin, and they do not reduce cardiovascular disease and renal disease up and above their reduction of glucose levels. But other medications do, and I'll talk you through that as we go along. Just briefly, and just so you know, we do have separate webinars on each of these medications. So the second webinar will be mainly on the oral glucose lowering therapies, the third on empagliflozin and GLP-1 receptor agonists, and the fourth on insulin and sulfonylureas. So we will go over these in a lot more detail, but just in brief. So the reason why metformin is still first line is it does reduce cardiovascular, it actually does both cardiovascular and renal disease independently of glucose levels. So does empagliflozin and your GLP-1 receptor agonists. There's actually more and more data coming out that both the GLP-1 receptor agonists, both liraglutide and liraglutide and empagliflozin, are also good for heart failure and renal failure. So we'll go through that too. Pioglitazone is an old medication which is still very good at reducing cardiovascular disease, and that has actually moved up a wee bit up our ladder of treatment. I'll talk more about that. As I said, metformin, empagliflozin, dulaglutide, and liraglutide also lead to weight loss and do not cause low glucose levels alone. Vildagliptin, or Galvus, is a useful medication, but it's one of our weakest. It only reduces HbA1c by about 5 to 10 millimole per mole at most. It doesn't change weight or have any benefits on cardiovascular renal disease up and above glucose levels. Acarbose, there's actually new data coming out that acarbose may lead to some weight loss. It was thought to be weight neutral with no independent benefits either. But that's where they sort of fit in to this picture. And one point I really want you to remember as well is that statins and ACE inhibitors or angiotensin receptor blockers remain just as important as ever for both cardiovascular disease, renal disease, and heart failure. All these benefits of the glucose-lowering medications are up and above those. So please do remember your tried and true medications as well. Now, this is where our new management algorithm sits. It's also on Health Pathways, but I'd encourage you to have a look at our National Diabetes Guidance, which is on this website here. We've also got it in our Moodle resources and in our Aotearoa Diabetes Collective resources as well. But this is what the pictorial looks like, and we'll just go through this in more detail. So in terms of, excuse me, the first thing is actually confirming the diagnosis immediately. We're not waiting. Part of it is actually working out what type of diabetes they have, which, to be honest, I think is still the hardest part of my job. Sometimes it's not straightforward. even though at least 90% is type 2 diabetes. And we'll talk about those red flags as we go along, which may be different types of diabetes. Doesn't matter what type of diabetes you have, lifestyle management is still the cornerstone throughout the journey with diabetes. If it is type 2 diabetes, we're starting metformin with lifestyle management at diagnosis, and we're starting low and slow and going to our maximum tolerated dose. We don't tend to go above 2 grams a day or 1 gram twice daily, and that's because doses above that typically don't reduce glucose levels much, but you do get that adverse effects. So that's where we start off. If it is type 2 diabetes, everything I say will be assuming it's type 2 diabetes moving forward. We are thinking about a personalised weight management plan, if appropriate. We are thinking about, can we achieve, remission here, or at least get significant improvement. We're going to individualise our target, which for most I said is less than 53 millimole per mole. We're actually thinking about adding in another agent if the HbA1c is above 64. We're also thinking about if they have insulin deficiency, or there are red flags for other type of diabetes, about starting insulin too. Now, the next question you have to ask yourself is, do they have basically cardiovascular disease or renal disease? Now, renal disease, the urinary albumin to creatinine ratio is above 3 milligram per millimole, or eGFR less than 60. Either of those counts as renal disease. Heart failure is normal, and it could be any cardiovascular disease. Doesn't matter if it's heart disease, cerebrovascular disease, peripheral vascular disease, and a 5-year cardiovascular risk greater than 15%. That's actually going to reduce down to 10%, but I'll talk more about that as we go along. Basically, if they've got cardiovascular or renal disease, you're going to make sure that they're on a statin and ACE inhibitor ARB. If they've got renal disease or heart failure, we're then going to add in empagliflozin or GLP-1 receptor agonist independently of what their HbA1c is. Now, that is because we know that those medications prevent the progression of cardiovascular and renal disease independently of their effective glucose levels. And through the course, and particularly in that webinar on those topics, we'll talk about that mismatch between the special authority criteria. Just to be clear, the special authority criteria for any medication is not what best practice is. It's limited by Pharmac for financial purposes. So we'll talk about both best practice and what's pragmatic in the funding environment. If they don't have cardiovascular renal disease, you may still choose to use empagliflozin or dulaglutide or liraglutide if HbA1c is above target, but you can also think about your other medications as well. And part as we've got along is just talking about what may push you one way or sway you another. The next part is making sure that you escalate therapy at least every 3 months until you've reached your target. And it's also raising the point for those with cardiovascular and renal disease, actually being on both empagliflozin and dulaglutide or liraglutide is preferable if the HbA1c is above target. And there's now certain scenarios where you can achieve that funded, as I mentioned earlier in the introduction. So there are some other changes to the guidance as well. And so there is new national cardio-kidney metabolic guidance coming out, which actually closely aligns to our diabetes guidance anyhow, which is handy. But if you have diabetes and you have any vascular complication, and the most common ones are diabetic renal disease or eye disease, that's anything abnormal on photo screening, or foot disease, you want to start lipid-lowering therapy, aiming for an LDL less than 1.4 millimole per litre. And now with the more potent agents, it's actually achievable to get there. And we're aiming for a systolic blood pressure between 120 to 129 millimeters of mercury. It doesn't matter if it's lower than 120 if it's well tolerated, but it's getting that picture in mind. Just that you know, controlling blood pressure and lipids is likely as important, if not more important, than controlling glucose levels at reducing complications of diabetes. It shouldn't be forgotten. You also see a lot more advice on lifestyle, including ways to increase movement, just not exercise. Sleep is really important. Sleep deprivation is one of the biggest causes of increased appetite, weight gain, and high glucose levels. It's about addressing that as well as other aspects of holistic care. It's also thinking about how to use continuous glucose monitoring or CGM, how to interpret it. We have changed the management of hypoglycemia or low glucose levels away as well to be more effective. And just another point, it wasn't that long ago, and many of you will still remember, when if you had diabetes, you'd start on, everyone would be started on aspirin, ACE inhibitor, and metformin. The metformin's staying, but we now really no longer use aspirin for primary prevention in people with diabetes. And that's because we know that it's not as effective in people without diabetes and actually increased bleeding risk. So typically the risks outweigh the benefits for primary prevention, still just as important for secondary prevention as ever. For ACE inhibitors and ARBs, we know they don't prevent renal disease. They're very good agents once people develop diabetic renal disease. But actually, if someone had high blood pressure without renal disease, our go-to would actually be a low-dose ACE inhibitor and calcium channel blocker. And we'll talk more about that as when we come up to management of high blood pressure as well. But it's just to let you know there's been lots happening in the diabetes space to improve care. It's about how we can implement that really into action. So part of that is thinking about what tools do you have that's available to help. So I've just shown you the website for the NZSD guidance. Basically, I've put that all into health pathways, and it is a national health pathway. It should be the same health pathway in every region. The referral criteria has changed. It's just that, that's a good go-to. And we've also been working with Healthify, which used to be Health Navigator, to make sure our whānau-facing resources are also up to date. And then there's a growing number of local diabetes resources and dashboards, which I'll go through quickly as well. So here's the website again for our National Diabetes Guidance. There's the front page there. Basically, if you can click on any section, such as here's the medications, it'll then give you basically, hopefully, a one-stop shop, everything you need to know. And I personally think it's a lot easier to navigate than Health Pathways, which often changes the formatting and the language. That's there. It's available for anybody to use and try and keep it up to date and live. Everything is on Health Pathways, as I'm sure 99% of you are very familiar with, but it's another go-to spot for guidance. Please feel free to print off or save the PDF to the desktop, or the growing number of resources on Healthify. Selita has also put together some fantastic resources on all aspects of diabetes care as part of this course. And you can find that under the key links in the resources tab as well, which you may find useful for all of you people with diabetes. Now, for the local diabetes resources, this really varies by PHO and by district, but many PHOs now have an identifiable diabetes leads who'd like a go-to for advice to let you know what's available in your region. We've also developed, for example, in the Waikato, every practice has a diabetes manual that we update every year or so to make sure that everyone has up-to-date advice that they can go to there if they need to. I will have a plea here about using your multidisciplinary team and those that you have involved in your PHO or practice. Many PHOs now have dietitians embedded with them. It's absolutely fantastic, including Kaya Fina is health coaches, health improvement practitioners. Don't forget the pharmacist as well. I'll be honest, I get the pharmacists do lots of education for me, some time poor in the appointment. I'm sure you are. The other plea I put in here is don't forget secondary care. And the reason why I say that is, for many aspects of for care, we receive less than half of those referrals for less than half of those that are eligible. There are many reasons for that, but it's actually making sure that people are aware of what's actually available in your region. There are lots and lots of education resources on out there on various platforms, including Goodfellow. So I've just done, I've done quite a few like podcasts, videos there. We can have resources, links to others. Also, many practices now have, or within the PHO, local dashboards. Also got a national dashboard for, it's almost there for GPNZ, which would be fantastic given that whole country coverage. We've also started working on national diabetes platform, which is desperately needed. So we know who's got diabetes in Aotearoa. That's exciting work as well. But there's just one example that you can look at in terms of knowing, it's just basically an easy way of putting filters. It does all the hard work for you, but knowing are the right people on the right glucose lowering therapies, how do I compare to other practices, who's most at risk. We've also got buttons over the side that you push and lets you know which patients aren't meeting the targets. So you can push on that button and do proactive care. So it's once again, it's just really trying to make the most of the tools that you have, because we know how stretched everyone is, and anything that can help will be fantastic. So it's just a brief run through of, I guess, over the last few years, the major changes. There are some big ones coming as well. And just to start off with, we're finally going to align our diagnostic criteria for diabetes and pre-diabetes with the rest of the world. So we're the only country in the world that stands alone here. And we need to change that. What that means, though, is that once your HbA1c is 48 millimole per mole above, that is consistent with diabetes. It's not above 50 anymore. That will mean roughly another 40,000 New Zealanders will have diabetes. And we'll talk through guidance around that, what to do with that group. To be honest, it's the same anyway. It's lifestyle management, metformin, regardless of whether it was 48 or 50. And that's, I think it's important to know that it varies a lot from practice to practice. There are lots of people with pre-diabetes who are being treated with lifestyle management and metformin. There are lots of people that are high risk, that did have diabetes, weren't being treated at all. And so it's trying to align that. Pre-diabetes is now 42 to 47 millimole per mole, and less than that is normal. So you will have, those very, very low risk people that didn't have an HbA1c of 41, for example, they no longer have pre-diabetes. They don't need annual screening. We do have that national consensus guidance for all cardiac kidney metabolic disease. We know that people just don't come in bits. It's just not diabetes. It's just not heart failure or high blood pressure. We've now got consensus targets, which I'll go through, and I'll make sure these are all incorporated within each of our individual talks. But some of the big changes on that is including new management for weight loss, and also just knowing that high cardiovascular risk is going to move down to 10% and not 15%. There are other things which will make people high risk as well, which we'll go through. It's about getting that proactive treatment early. The other thing which I think will continue to change, and we're actually doing quite well in this space, hopefully in turn we have access to extend and release metformin soon, funded, but we are also finally going to get semaglutide and tirzepatide here, which will not be funded. Now, these are the newer GLP-1 receptor agonists. You would have heard of Ozempic, Wegovy, and Mounjaro, I'm sure. They are a lot more effective at terms of reducing cardiovascular disease, at improving HbA1c and weight loss as well. What we do need to do is get access to those who need it, but they will be here too. So things are gradually changing quite a bit. So at the end of every webinar, I do like to have some take-home messages. The first one is just really thinking, I'm now no longer treating glucose levels. I'm treating based on the cardiovascular and renal disease burden. I'm aiming for weight loss wherever it's appropriate. So that's a big, big change in just the mindset of management. You're thinking about every opportunity. How can I make changes? How can I actually empower whānau to make their own changes? How can we set them up to titrate their own medications? We'll talk about that as we go along as well. It's not just at their appointment. Remember that people with diabetes only see you for well less than 1% of their lives. How can we make sure they're doing it the rest of the time? Know what resources are available. I hope you'll find this course an invaluable resource. Please feel free to share it with anyone else in your practice. There's no copyright or anything like that. It's about making sure people know how to manage diabetes in Aotearoa, but actually find out what you've got in your region as well. And we'll go through sort of synced up-to-date advice. And we'll cover the whole spectrum of diabetes care. And we'll try and give each one justice. But thank you for coming along and being part of this journey. So here's actually the timetable here. I know Salita sent it around on via email. But our next webinar is a big one actually, and that will be next Monday and Thursday there. Just be aware that Thursday will be a recording of the Monday evening, but we're going to talk about what the new recommendations are for lifestyle management, and we're going to talk about, in terms of our medications, what's the role, how do we use metformin, vildagliptin, pioglitazone, and carbos. We're going to cover that in one webinar. But you can see there, There are the other webinars that are coming up across those 8 weeks. And remember to please complete your multiple choice questions. There's also just one question there, just getting attendance and feedback. Really value your feedback to try and improve this course. Please also feel free to start sending questions through now. So we'll go through questions in a second from tonight, but you might have questions about, certain cases in your practice or just what you want to learn. We will include these in our case discussion and mentoring sessions as we go along. Brian's starting to put them all together already. So please feel free to send them through at any stage. Here is just what your Moodle looks like in terms of where you find the multiple choice questions. It's just here, just below where you would have clicked in for the link. And you've got down there, you just have to go in for each webinar as you go along. It's easy to do it straight away, but you can do it at any time. So thank you all for listening. I'm just going to hand over to Salita now, and we'll go through the questions.
Kia ora. Sorry, can you just confirm you can hear me? Because I've just put on
all-
a headset while the toddler's
all
going
good,
to
Salita.
bed. Cool. I'm just going to try and see if Brian can introduce himself. Otherwise, I will pass on his messages. But in the meantime, let's start with the Q&A. So, there you are, Brian.
There I am. Can you hear me
Go for
okay?
it.
We can,
Yes,
Brian.
we can.
Oh, cool. That's excellent. Tēnā koutou katoa, ko Brian Gibbison, toko ingoa. Hi, everyone. You're going to see a lot more of me in the mentoring phase of the program. But I just thought I'd jump on and say hi at the present point in time. Actually, no, you're going to see me during the Thursday sessions as well with Brian, because I'll be co-hosting with him if I can get my links sorted out for uni. Which will be joy. I just wanted to say, so with the mentoring sessions coming up in the second phase after the school holidays, I'm away for part of June, July. So if you've got a case already that you are thinking, I'd really like to put this forward, please send it through now. So send it through to the education@aotearoa diabetescollective.org.nz email. Try and have a go with saying, give me all the details, but try and say, this is what I think I would do. Okay. Now, I take it that actually you may not think you know what you're going to do because that was the purpose of being part of this webinar program, but just, give it a best shot, basically, what you think you should do. We'll talk about it early on, but as we go through the webinars and into the mentoring sessions, one of the things we will be looking for is to actually go, provide me with your case, but then give me some ideas of what you're going to do based on the learning that you've got out of the webinars, okay? It just gives us some idea of, are we getting our message across properly in the way we need to? We will make the sessions when we get there as interactive as we can. Last year we used lots of polls and so forth as well. But at this stage, really, I just want people to be able to put something through, send me a case, give me something to go on that I can get at least that first session for mentoring in the latter part of July, ready before I go away in the middle of June. Okay, so that's all I wanted to say. Cool.
Yeah, thanks, Brian.
Wonderful, thank you. And I have just made sure that the template is available for you to download on Moodle as well. So it's all templated and easy for you to fill in and then email straight to us. And it's got kind of the vital information that we need to be able to answer your question properly, because there's nothing worse than wanting to do our best to answer, but we're actually missing some key bits of info. So the first question is, are there any subtypes or gradings of type 2 diabetes? And are there any lab tests or genetic tests to classify type 2 diabetes further, pharmacogenetic testing?
Yeah, I will say it's mostly academic research at present. Part of it, type 2 diabetes is a very, I'll be honest, heterogeneous condition in terms of encompasses a big group of people. There are gene tests that you can do, particularly for monogenic diabetes, which we'll talk about very briefly in one of the final webinars, where basically variants of genes do cause diabetes, but it's not strictly type 2 diabetes. I think at this stage, though, you will find that different people respond differently to different medications. You may decide to try different medications based on that. But at this stage, it is still very much a structured approach to everyone with type 2 diabetes, but appreciate the nuances within that.
Awesome. So the next question is between ACE inhibitors and ARBs in patients with type 2 diabetes, which has the better cardio and renal benefits?
Yeah, it's a good question. In many ways, I will say it's much of a muchness, and you're really getting into fine detail. Key point is don't use both together. Please just use an ACE inhibitor or ARB, and I tend to stick to those with sort of a longer action profile and more favourable. So for ACE inhibitors, to be honest, I tend to use ramipril, occasionally perindopril. For ARBs, I use candesartan, but if they do have gout, I can often have my arm twisted towards losartan. That's been shown to lower uric acid levels. And we'll actually talk about some of those nuances when we come to our management of high blood pressure webinar.
And there is some data to show that ACE inhibitors have better mortality outcomes in people with heart failure too, eh?
Yeah, and I mean, part of it would be, do I want to put up with the risk of a cough, for example, and go straight to ARB? There are lots of nuances, but I think if you look at big picture, you could argue that as sort of at this stage, much of a muchness between the two classes.
Great. So someone has asked regarding empagliflozin, which for those, we often get a lot of people getting confused between the names. So empagliflozin is Jardiance, and we'll try our best to use both names throughout. We're advised to stop this during sick days with no food intake if it doesn't cause hypos. Why is this?
Yeah, it's a good question. That is because empagliflozin can cause diabetic ketoacidosis or DKA. And so that's why it's really important to stop it when people are sick and not to restart it again to eating and drinking normally. It's also why we don't use empagliflozin in low carb or particularly not ketogenic diets, just because of that risk of DKA. It is rare, but if you stop it basically during sick days, you pretty much do very well in preventing it full stop. But it does mean, previously you may have thought, I need to stop the metformin, I need to stop the Vildagliptin, I need to stop the pioglitazone when they're unwell. You don't need to do that anymore. You might still choose to do it if they've got a tummy bug, for example, but otherwise they're not going to go low. It's only insulin and sulfonylureas where people are at risk of going low.
And we've also just added a type 2 diabetes sick day patient handout onto the ADC website, which I will add into Moodle as well. And Healthify have got some great resources there, which can be quite useful to text people that link as well via your practice management system. So in the aged care setting, at what age is it not necessary to reduce HbA1c, i.e. a 94-year-old with an HbA1c of 76 already on 2 oral agents?
Yeah, well, that's another very good question. I think it's about, I wouldn't use age as a number. I'd more go off frailty, actually, what you think life expectancy is. For example, we know that we may have many 65-year-olds who will do well, very, very well to make 66. For other conditions such as cancer, I'm actually going to relax that. At the same time, we may have 70-year-olds who are going to live for another 30 years, all going well. So it does become a bit more based on life expectancy rather than pure age. One thing I will say though is pretty much for all of your diabetic complications such as renal disease or eye disease, it takes at least 10 to 15 years before the first sign of disease, before they end up with end-stage disease. So, so if they first start getting microalbuminuria, it's probably at least 15 years before they end up on dialysis as a rough guide. If you've got your 94-year-old that's basically got no diabetic complications, it is absolutely fine to relax your target. Realistically, they're not going to develop diabetic complications in their lifetime. So it is just weighing up the pros and the pros and cons. At the very most, you do want to avoid hypoglycemia in that age group. You may still say, look, Galvimet's absolutely fine. It's metformin and Vildagliptin in combination. It's well tolerated. It's not going to make them go low, but you do not want to be causing hypoglycemia in the elderly.
Awesome. Someone's asked, can diabetes be confirmed only by a GTT test and the HbA1c has been in a therapeutic range for the last 3 years?
Well, you can sometimes get discrepancy between HbA1c and a glucose tolerance test, which we can talk about if you wish to. But basically, you don't have to have a glucose tolerance test to confirm diabetes. That is still the mainstay in pregnancy, well, in the second and third trimesters. But otherwise, in the first trimester of pregnancy and everyone else throughout their entire lifetime, HbA1c, if that is above 48 soon, but 50 at the moment, that's diabetes. If the fasting glucose is above 7, or if you have a random glucose above 11, if they're symptomatic of high glucose levels, that would be anyone that's losing weight, got fatigue, polyuria, polydipsia, so drinking lots, peeing lots. That's consistent with diabetes as well, as above 11.1 on the 2-hour glucose tolerance test if you still choose to do that. So what you may choose to do, if you've got someone that is, you've got a really high suspicion they've got diabetes, you could choose to do an HbA1c and fasting glucose in the blood test, or you could just choose to do a finger prick there and then and give them a form to do the HbA1c. You've confirmed the diagnosis of diabetes straight away. It's still the 2 tests. But once you've got the 2 tests, that's it. You're going to move forward and treat and be aggressive. You don't need to wait. You can do 2 HbA1cs. And that may sound a bit like an oxymoron, but the reason why we do 2 tests is one is to reduce, there is still about a 1% possibility of lab error, but 2, we're just bearing in mind that it does have a significant impact across their lifetime of having a diagnosis of diabetes. So that's why it's a 2 confirmatory tests. But you can do, one right there with a person within the practice, and the other one you're doing straight away.
Awesome. Someone has also just asked about whether we need 1 or 2 HbA1cs above 50. I'll also just add to that, I'll make sure that we've got a link to the paper, but the International Consensus of Remission of Type 2 Diabetes. So quite often I get asked to review people who have a historic diagnosis of diabetes because they had 1 HbA1c above 50, and someone's been very proactive and gone and classified them. But actually, if they've maintained an HbA1c less than 48 without any oral agents for over 3 months, then that can classify as remission of type 2 diabetes. But the thing is, you want to be having a conversation with the person, because if you remove that classification, then it affects their screening. So, and it also affects things like funded flu vaccines. So, but in Polar, you can also reduce things like their life insurance or travel insurance and things like that. So it's something to have a conversation with people about.
Yeah, and they're really, really good questions that keep coming through.
Yeah, thank you. Someone said, what's the process for diabetes annual review if the HbA1c is less than 50?
Yeah, so that's, I guess, along those lines. One, I guess, if they are having hypoglycemia because on insulin sulfonylurea, you may actually relax treatment and maximize it in other ways. The way that treatment's arrived in Aotearoa is that you actually have many people now who are on insulin who can actually get off insulin with the newer medications that come along, which should always be our goal. So even though the HbA1c is a target, you may still choose to change their glucose lowering therapies. But then you're thinking about, we'll just put that to one side. What am I going to be doing about, screening for complications and things? There's no real international consensus on this, but what I would recommend is that if they do have known diabetic complications, that you do still keep screening every year, or every 2 years for photo screening, probably for at least a few years, to make sure that their complication burden hasn't increased, because that can still happen in the pre-diabetes range. If they don't have complications, then to be honest, there's no real benefit in getting your HbA1c below 45. So what that means is, if an HbA1c is below, say it was 44, I do not escalate treatment at all. In fact, you may be tempted to withdraw something. Just be aware though, if you're taking glucose lowering medication away, that the HbA1c in 3 months may be a lot higher. You may need to put it back in. So just be aware if you do stop something. But once you're in, I guess, remission, so to speak, these people have already declared themselves as being high risk for diabetes. So this is one group that even if you do stop doing a diabetes annual review, please do the HbA1c every year, at least for the first 5 years, to make sure they haven't gone back to developing type 2 diabetes.
Awesome. Someone's asked if they can have a copy of the slides. So all of the slides for the next 3 webinars are uploaded, providing that we keep being proactive and organized. We will try and keep them uploaded ahead of time. It just
Worst case
depends on the
scenario,
workload a
available
little bit.
Yep.
And yeah, we will do our best. But when it comes to mentoring, it can be really difficult because we're relying on people across the MDT to, gift us their time and expertise. And sometimes those presentations don't come to us until the day of. So we'll always do our best to get them up ahead of time. So someone's asked, how do they access the local diabetes dashboard?
Yes, I'll be honest, it is very PHO dependent. It'll be about most of the big PHOs now will have a dashboard. My biggest piece of advice is asking your diabetes lead within your PHO about whether you can access it. Because I'll be honest, I can't tell you each of the individual PHOs that have it or not. And I'll go through that avenue. Sometimes they may actually have a dashboard but not be sharing it with practices. But it's eventually going to change, but it's just, you can imagine the IT world getting that off the ground.
Someone has asked, will we ever be able to start medicines on day 1 rather than pretending for 3 months? And someone's added on, especially for Jardiance and GLP-1 receptor agonists for those who are high risk.
Yep. We would love that to be the case. And here's one very good example where there's a complete mismatch between the special authority and what is best practice. Best practice, yes, from day 1. It makes no sense to wait. It's now 6 months, the new special authority criteria. That's just leading to harm. We've now got empagliflozin for heart failure. So I'll be honest, if I've got any signs of heart failure, I try and get empagliflozin from the beginning. We will also hopefully have empagliflozin for non-diabetic renal disease very soon. We're obviously advocating strongly to have basically open listing of empagliflozin and GLP-1 receptor agonists as well. So it's a work in progress, and not that I want to encourage you to feel uncomfortable about doing special authority criteria, etc. I think it's about doing all you can to access people the right treatment as fast as possible. Sometimes people choose to self-fund in that situation. There are ways around it, and actually it's a big part of our 3rd webinar is ways how we can actually access these medications for people that need it.
We've also got our disability allowance guide, and we've got a pharmacy up in Auckland who offer Jardiance for the cheapest price that we've been able to find, and they do free delivery as well. So what I do for a lot of people in this situation is I'll put out on a plate essentially what I would do in a best case situation if funding wasn't a problem. And you can always offer to people that they can self-fund Jardiance for the first 3 months and then change them over to funded, and you can do half of a 25 milligram tablet to half the price, and you can shop around pharmacies, and some pharmacies are really, really reasonable with helping to reduce the cost for those where cost is a barrier, especially if they know that the person will be getting funded Jardiance very soon. The next person has asked, is there any evidence for taking aspirin as a primary prevention for people with high cardiovascular risk greater than 15%?
Yeah, that becomes a group. It's a good question because you always weigh up, I guess, the risks and benefits. Typically, that's the group that's got the most to gain. That's also the one with the greatest bleeding risk. So yes, it's the short answer. I think it's always you have that conversation with people and decide what they want. The aspirin harm calculators can be useful to help guide that. But as a general rule of thumb, generally for those with diabetes or significant renal disease, we're not using aspirin for primary prevention. But there may be there's never 100% rule in medicine, and it's just about going through that with the patient.
I'm just making a note that I'm going to add MedCalc to the resources because that's got a lot of those really helpful calculators there for you. Someone's asked, is diabetes reversible?
Yeah, type 2 diabetes is, yes. And that is where weight loss is so important. That's the main way we can reverse type 2 diabetes. Unfortunately, we've got there is still no cure or reversing type 1 diabetes or pancreagenic diabetes once they've lost their pancreas. Same for monogenic diabetes, but saying that over 90% of diabetes in Aotearoa is type 2 diabetes. Yes, I think we should be aiming to reverse it if we can, and it's appropriate. It's just criminal we don't have a national remission program and like that. And we'll go through the ways to, I guess, best practice for aiming for weight loss where it's appropriate, because there are some, we'll talk about some more detail because I don't want to keep people at night. But there are sort of current practices, particularly on social media and stuff, which are completely false and just leading to harm. And we'll try and talk about that in more detail during that webinar.
And our wonderful dietitian in the mentoring session does a
It's a really good
beautiful job
session.
of covering that.
Yeah.
If there's a session that I highly, highly recommend, it is that one. So for a Māori patient newly diagnosed with type 2 diabetes with an A1C greater than 75, can we start empagliflozin straight away? Already talked to that.
Well, you have spoken. Best practices, yes. If it is appropriate, I'll be honest, I try and find every excuse I can, and that may include, previous time treated with metformin in the past, for example, and the HbA1c is still above target. Or that's, to be honest, personally, I count that as being away. Or they may actually, what you may do is, do they have evidence of renal disease, etc. diagnosis, which many people do, unfortunately. And that can be something which will definitely twist your arm towards doing it as well. I think you want to follow the guidelines set out by Pharmac, but you're just trying to maximise access as much as possible.
Sometimes you can also have a quick look through a recent hospital admission, because a lot of these people have, not necessarily presented for screening regularly, and they may well have had diabetes for well over 3 months. So if you can find an old high glucose level from, even years ago, that can sometimes help as well. So we've got someone with impaired glucose tolerance starting metformin. Wondering about whether or not it can prevent progression to type 2 diabetes.
Yeah, and that's one thing we'll talk about. Metformin definitely does, and metformin and vildagliptin in combination is even better in terms of reducing your progression. We don't really have the new data on the newer medications where they do it, but that is one reason why we use metformin in combination with lifestyle management right from day one, is it slows down that progression, increases your chance of remission. It leads to a little bit of weight loss alone. It reduces cardiovascular and renal disease up and above the effect of lowering glucose levels. It's also been shown to reduce solid cancers, etc. As well. So there are lots of reasons for that, but that is one of the key reasons, is about slowing down that progression and giving you the best chance of remission.
They've also asked, is there any reason not to do this in people who are keen?
No, I think we do. It's something which is underdone in terms of not only at diagnosis, but our high-risk whānau with pre-diabetes. I'm going to just caveat that a wee bit, and I'll talk more about this when we cover pre-diabetes. But ideally, everyone with high-risk pre-diabetes will actually be doing lifestyle management and metformin as well, aiming to reverse their pre-diabetes. Where it comes a bit iffy is when you've got low-risk pre-diabetes. And just as a typical example, you may have like a 75-year-old elderly woman who's had, HbA1c's between 40 to 43 over the last 15 years, hasn't progressed, is very low risk of developing significant diabetes in their lifetime. That's not necessarily the group we want to be targeting. But hey, if you've got a young, Māori man, 22 years of age, with an HbA1c of 46, and it was 40 a year ago, that is someone you definitely want to be targeting. So yes, the simple answer is yes. We'll cover those nuances a wee bit more when we come to our pre-diabetes webinar. But in many ways, there's no perfect cutoff for diabetes, and it's that high-risk group are the ones we need to be targeting to stop the burden in their lifetime.
Cool. Someone's asked, are you saying that there's no genetic predisposition to diabetes for Māori and Pacifica?
Yes, to diabetes, but not necessarily to cardiovascular disease from diabetes, and that's it. There is look, there are many reasons for why there's greater prevalence of diabetes in Māori and Pacific people, and particularly for renal disease up and above that. But if you look at basically, you take cardiovascular disease, for example, if you take away smoking, high blood pressure, etc., it's actually protective to be a Māori man in terms of your overall risk of cardiovascular disease. And you think about how many of our Māori men we've lost far too early from cardiovascular disease and diabetes. It's not the fact that, it's not ethnicity causing that. It's what we can change. Sometimes we feel powerless around, the socioeconomic factors, but we can make a really big difference for the modifiable risk factors. And that's where it's really encouraging people to try and target. And just so people are clear, there's no one gene that controls type 2 diabetes either. There's multiple genes involved. We know they run through whānau, but there's there's no perfect way to do a risk score. There's no precision medicine as standard practice yet. We're getting closer to that in terms of knowing who will respond to metformin and who will respond to empagliflozin or Jardiance, etc., but we're not there yet. And that's why it's still a bit of a blanket approach. But it's just, being aware that, we can actually reverse some of these disparities is what we should be aiming to do.
It leads quite nicely into this question. So looking at the data regarding diabetes and the age of onset becoming younger, regarding obesity and pre-diabetes, don't we also need to tackle the social determinants? Because a lot of people I see are below the poverty line and can't afford the basics and just trying to exist. So they're on a perpetual wheel. Many don't have a GP.
Yeah,
100%.
And that's the key. I couldn't agree more. That is the key to all of this. There are so many parts that go into that as well in terms of the social determinants of health. That's why it's fantastic if you do have access to a social worker in your practice of PHA, which I know is increasing. They can be worth their weight in gold. That's why we're desperately trying to change our models of care. But it's those, sometimes we do feel powerless as individual people. We know how much of it is just the social factors that are out of our control. But we need to address it all. It's why holistic care is so important. But it's also doing what we can do, and not necessarily just saying, "Oh, that's social determinants of health. I can't do anything," as you can still make a difference. So I don't want to downplay the social determinants of health, but absolutely key.
Someone's asked, can you provide some links for some good patient information about things like DKA? A lot of patients want to educate themselves, but there's really basic info on Healthify where it's too complicated. So I believe, well, I do know that Healthify have actually just updated their handout also to suit heart failure as well for empagliflozin. There's also there's also a couple of other resources, I believe, that are in our resources section on Moodle. But one of the key ones that I think is really helpful is the old pharmacoketone booklet, because it goes through the common symptoms of DKA. But the thing to just really be mindful of is that a lot of the time that people just need to know when to present to a healthcare facility, because we don't want them trying to manage those symptoms at home.
No, exactly. And we'll talk about that, particularly around empagliflozin or Jardiance. The other thing is I really encourage you to check out the resources section of Moodle. But Salita's done a fantastic job. We're actually trying to create a national pool of resources as well, that we can grow to cover all aspects of diabetes. So it is watch this space. If you know a good resource, feel free to share it. Like, it's a great way of getting to know it. We just want to help each other.
Yeah, so I think I've got, I'll triple check that I've got the CareSense ketone one on there, and if not, I will get it uploaded ASAP. Are there any patient groups where HbA1c is not reliable for diabetes diagnosis or management?
Yeah, that's a good question. Because there is, particularly for Māori and Pacific and Aotearoa, and for Africans that they do, well, have a slightly higher HbA1c for the same glucose levels. Saying that, lots of that data isn't matched appropriately, and there's arguments that people with like different ethnicities are faster glycators, which means that's why they get more complications from diabetes. The biggest thing I'll say is at the moment, I'll just take that out of the picture. In terms of the things that affect HbA1c the most, remember that HbA1c is only good as the hemoglobin. So if you've got any abnormality of hemoglobin, it may be a hemoglobinopathy, it may be a thalassemia, it may be bleeding, they may have just had a blood transfusion. Pregnancy is probably the biggest cause of altered red cell turnover. HbA1c becomes unreliable, and that's where glucose levels are most useful, and that may be CGM, it may be finger prick. Sometimes we still do the old fructosamine, which we'll talk about as well. Sometimes you can get a mild discrepancy with iron deficiency and with renal disease and with obesity, but we're really only talking about 5 millimole per mole at most for all of that. So please, if you do see an HbA1c, for example, that's 60, 70, they've got diabetes, just I wouldn't say it's a false value, because most of all these intricacies are only sort of less than 5 millimole per mole.
That's very helpful to know. Just please, if you are asking questions, put them into the Q&A. I will try and go back through the chat and double check that we've covered everything. So this is, I think, referring to back when you were talking about if their HbA1c like under 50 or soon to be under 48, and they're on vildagliptin and empagliflozin, what would you stop?
Yeah, so I'd always stop the medication that's the least benefit or potentially causing the most side effects, either one of those two, whichever one that is. Typically, if in that situation, I'll stop the vildagliptin because it's got no benefits up and above the effects on glucose levels. So you've kept in the empagliflozin or Jardiance. So that's always the question that you ask yourself each time when you're cutting back medications. Typically, it's insulin first gone, then sulfonylurea is second gone, then sort of vildagliptin acarbose as you work your way down the list.
Awesome. And if the diagnostic criteria for A1C changes to 48, will the treatment target also change or stay under 53?
No, it's going to stay under 53. So
is it going to say anything for younger people about being under 48 or no?
Oh, you're right, Steve. We will say for younger people less than 48. But it's bearing in mind that actually if you started everyone with an HbA1c, say you had a new diagnosis, so that was 49 or 50, if you start lifestyle management metformin, you're going to essentially get them all to target anyway. So you still, even though they're at target, you're still going with lifestyle advice, you're still going in with metformin, you're still aiming for remission of their diabetes if you can. It doesn't stop you from doing that, even though remember it's shifting away purely from the HbA1c cutoff. The only reason why the HbA1c is not shifting lower is it's just, potentially it's not any more benefit, so to speak.
Perfect. So this may be covered in another session, but for people with type 1 diabetes on an insulin pump and CGM or an closed loop system, how low is a safe HbA1c? Can we be aiming for non-diabetes ranges? They had always thought no, but they're obviously seeing more evidence to support it.
Yeah, yes is the short answer. I'll be honest, we won't cover type 1 diabetes pretty much at all during this. We're focusing mainly on type 2 diabetes. But when you're on automated insulin delivery, and what that means for people that don't know, is you've got a pump and a sensor. There's also an algorithm which may sit on the pump or the phone, and they all talk to each other. So if the glucose levels are high, the pump will give more insulin. If the glucose levels are heading down low, the pump will give less insulin. So what that means is you pretty much reduce most of the high or low glucose levels, particularly if you get the settings right. So you can actually get near normal glucose levels without hypoglycemia, and that's what we're trying to do with everyone, but a pump can make that easier. So yes is the short answer. As long as they're not getting hypos, that they're safe. Also, just bear in mind that actually the people we know who are most at risk of really bad hypos are those with a high HbA1c, because they're potentially the ones that just take the insulin every now and then. When they do take the insulin, that's when they get the lows. So just be very careful using HbA1c as your guide to their risk of hypoglycemia. Obviously, if it is low on insulin, it does make you think about it, but also think about those with a high HbA1c on insulin as well. So potentially they're actually at greater risk.
So also just a shameless plug for our social media. We've got some really kind of broken down things on what to look at for the time in range. But generally, if you are looking at someone's CGM report, the international guidelines are that we want greater than 70% of time in range and less than 4% of time below 3.9. So in these instances, a lot of people have added some really helpful comments and examples. You can look at the CGM time below target range, and feel free, if you want us to cover some of these things a little bit more in detail, to send them through as a case for mentoring, because we can often cover some of that learning that might not have been covered in the webinars,
That's a
if
good
you're
point.
seeing more.
Yeah, as I say, we're going to go through CGM in a lot more detail as well, and that will apply
Yes.
to type 1 and type 2 diabetes. So, yeah, please, as Selita said, just please feel free to keep asking questions.
So is there a test to check for insulin levels, and is there evidence on keeping insulin levels stable and helping the progression of prevent the progression of diabetes and the support weight loss?
Yeah, so you can measure insulin itself, but what we use is measure C-peptide, and we'll talk about this as we go along. But the short version is when insulin secreted, C-peptide gets cleaved off, and that hangs around about 9 to 10 times longer in the bloodstream than insulin. So that gives us a better marker of their own insulin production. It can be useful as a guide, but it's definitely not the be-all and end-all in terms of, what's their, the risk of diabetes, is it change in management? It's much more for academic sort of research purposes. But it can give you, it does give some indication to the degree of how well beta cells are pumping out insulin and how resistant people are to insulin as well. It's obviously completely related to what the glucose level at the time. So please, if you do a C-peptide, make sure you do it with a glucose level as well. Without the two, to be honest, it can be a little bit useless. And yeah, but I'll be honest, it's a very, very rough poor man's guide. I wouldn't hang your head on it. When we look at weight loss, it's something we can measure, but to be honest, the actual weight itself is a better guide. We'll talk more about sort of remission and weight loss as we go along. The good news is when most people lose weight, they typically lose the visceral fat or the bad fat first, which is what's really important. But yeah, I'll be honest, it's getting quite into minutiae detail.
Would you say it's better for helping you to differentiate the type of diabetes that you're dealing with?
That's a good point. That's the main role for C-peptide or measuring insulin levels. It's not actually to monitor progression, but to help to determine the type of diabetes. Particularly when you're more than 3 years from diagnosis, it's the best test that we've got to help with that. And we'll talk about that. I think that's in our last webinar. We talk about that in detail.
Cool. They've asked as well that they encountered someone who had one episode of an elevated A1C query secondary to olanzapine, which is an atypical antipsychotic. The A1C then improved to the 40s without any intervention and now is elevated again a few years later. Would we start orals or wait to see if the A1C improves again without intervention?
I'll probably do a second test straight away, determine whether they've got diabetes or not. That's a situation where you may find glucose level, doing a fasting glucose or even a finger prick useful, as it gives you an answer straight away and you can confirm that. So just as you mentioned a really good point about olanzapine. So all of our people who are on antipsychotics, severe mental illness, particularly schizophrenia, they die about 30, 35 years before their peers. It's all due to metabolic disease, including diabetes. It's not actually due to mental illness or the effects of that. So I'll make that clear, they're a really high risk group. There's lots of mechanisms involved for why it puts up their glucose levels, but it does declare them as high risk. They're a really important group to go hard on, and also to follow up as well. Here's a classic example. Later on, you may talk to their mental health team, or maybe yourself in charge, and think about, do I use a more metabolic friendly antipsychotic? It can be obviously you want to treat the whole patient, but it's definitely one where I'd have a very, very low threshold. Even if the HbA1c was in the, if it's in the high 40s before you start an antipsychotic, that's a group I'd be thinking about starting at the same time. Because they're such a high risk group. They will, they will suffer detrimental effects from their high glucose levels.
Yeah.
It's the, it may be the better of two evils, because obviously their mental health may take have paramount importance, but please, it's one group we need to do a lot better with.
There are some psychiatrists who are now sort of starting metformin alongside the atypical and those people where they can already see they're really high risk, but definitely flag it with them if you come across people like that. And then they've also asked about people with steroid-induced hyperglycemia. Are these people high risk, and do they need to be screened regularly?
Yeah, so we'll cover this. We've actually got a special part on steroid-induced diabetes, because it's so common. Just be aware, steroids are different from antipsychotics. So steroids mainly cause high glucose levels because they stop the pancreas from producing insulin. So the way that you treat steroid-induced diabetes is with sulfonylureas or insulin. That are the mainstays of treatment. It all depends on the underlying circumstances. If you've got someone that's on long-term steroids, or if you've got someone that's on regular intermittent courses, whether it be for chemotherapy, asthma, COPD, etc., yes, I would be treating their diabetes. It's often actually their high glucose levels that's making them feel crap during chemotherapy, for example. Treating their glucose levels can make their quality of life a lot higher, and it's also linked to improved mortality and stuff as well. So yes is the short answer. At the same time, you may have someone, for example, with gout who you're only giving 3 days worth of steroids, and that's it, and you may choose to ride that out. So we'll go through once again some of those nuances, because it is a very important area.
Awesome. I'm just mindful of the time. We've still got over 200 people on board, so we'll keep plugging away if you've got time, right?
Yeah, keep going.
Okay.
We might call it in 15, 20 minutes though.
Okay.
Yeah.
It's great that you guys have asked so many questions though. So when is the new diagnostic criteria coming into effect? Are you allowed to tell us or have any idea?
No, the only thing is we're actually trying to make sure we get all our ducks in a row. And that is just think about people like community labs to make sure it's all on reporting when that happens. We get a coordinated approach across the country. The biggest impact it's going to have is actually on retinal photo screening. And we know how overloaded they are in some regions. So we're just trying to make sure that all the sort of key parties, stakeholders, etc., are all lined up. But we want to happen in the next sort of 3 months. We've been waiting long enough. So expect some announcement on that soon. I'll let you know. You'll probably be the first to know during the course.
Yeah. Is there a high prevalence of people with sickle cell anemia in New Zealand, and do you use fructosamine in that case?
Yeah, no, we're lucky in that we don't have much sickle cell anemia at all. But yes, to use fructosamine. So that is one situation where you would. Sometimes you use it for thalassemia as well. I'll talk more about that when we get to that. But if you've got anyone that's basically got abnormal hemoglobin for those reasons we spoke about, fructosamine or glucose levels are your best guide to treatment and not HbA1c.
Awesome. Okay, a couple questions about the semaglutide and the current GLP-1. So is there, what's the possible reason that you mentioned that Mounjaro wouldn't be covered or funded?
Basically because unfortunately nothing for weight loss is covered or funded at present. So, I mean, we'd hope we will get there eventually, but when it comes out, it won't be funded. We don't have a price yet. I can imagine it's going to be at least $650 to $700 a month, which unfortunately puts it outside most people's financial capabilities. But having pharmacotherapy for weight loss is something we desperately need. We've spoken about social determinants of health and clinical obesity basically being the drivers of most of metabolic disease. And it wouldn't be nice if we're actually able to address the root of the cause, since we do have effective treatment. And that's something we just continue to work on. Some PHOs in some regions, in terms of secondary care, have chosen to self-fund or fund GLP-1 receptor agonists for people. You may be involved in little pilots like that, but we're trying to actively work with Pharmac in terms of to get them funded.
I'm just thinking we've got a slide that I'll put up shortly of the all of the glucose lowering agents that I'll add into the resources. But what I'll also do is add one of all the GLP-1 receptor agonists and what's indicated for weight loss versus what's indicated for diabetes, because it does
Yeah.
get a little bit confusing when the medications are the exact same, but it comes down to the actual brand and the
Brand.
dosing
Yep.
and what it's been licensed for. Someone has also asked will Ozempic be funded and will those on Trulicity be able to switch over?
No, Ozempic won't be funded initially either. That is something we'll obviously want to work on that. On terms, just let people know, within 6 months, people lose, I think roughly it's about 12% of body weight, which is obviously massive, and you're getting yourself into remission territory for lots of metabolic diseases, including diabetes. It would still be fine for people to switch over, but it just means, unfortunately, they're going to have to pay.
Awesome. And then someone's asked about whether or not you can check the glucose level using a Libre while they're on an insulin infusion in a hospital setting and change the rate of the infusion based on the CGM result, or should we be using manual glucose monitors?
Yes,
There
it's,
is, I'll
yeah.
let you answer and then I'll point you to some other resources as well.
Yeah, there is, I guess, a space that is changing fast. At the moment, I'll be honest, for at least 95% of people, it will be going by finger prick. And that is because people who are sick enough to be on insulin infusion are typically those who are sick enough to have fluid shifts, glucose shifts, etc., where CGM's thought potentially may be inaccurate. But I think what we will find is we will start to use CGM more and more in hospitals, particularly for those who are stable on the wards. Insulin infusion may be one of the last cabs of the rank for that, but it's a fast evolving space. And yeah, if you're involved in inpatient care, I will say just watch this space, but the answer right at this very point is no.
There is some research going on down in Christchurch and down in their ICU, for instance, they use the STAR protocol. And so they have an iPad where the CGM, but they're also managing other fluid balance and the IV nutrition and things as well. So it's a lot more complex, but they're effectively using algorithms to help guide those situations. And then there's also a CNS down there who's currently doing research and using the CGM in the ward setting and looking at the cost effectiveness in terms of the reduction of nursing hours and time and also the safety and efficacy. So there's research and hopefully there'll be growing kind of consensus about when it's safe.
Yeah. It's a really active space and it's literally changing week by week. And we're going to have new national diabetes and technology and hospital guidance coming out very shortly, which will actually increase our current use of technology in hospital.
Will there be national guidance on the insulin infusions as well?
It will change with time. I can guarantee that initially it will be no.
Yeah.
Potentially for those already on CGM, they come in, it's calibrated, etc. That there may be special things, but I don't want to distract from current protocols at present.
Awesome. And someone's also just asked about any hope for oral insulin. I wonder if they may also be referring to the intranasal insulin.
Yeah, so there is it's always been the dream to have insulin via non-injectable form, and there is preparations that become more and more effective. I don't know if people can remember inhaled insulin, which was a big thing. Then unfortunately it caused nasty interstitial lung disease, so it disappeared very fast. So yes, in terms of the other preparations, in terms of coming to New Zealand, I can't see it happening at all in the short term. One thing I'll be talking more and more about as this course goes along is insulin's a very good drug. It's fantastic when you need it, but our aim is actually use it less and less. and there's many reasons for that. But yeah, insulin still does remain important.
Awesome. And then our lovely Brian has also just added the comments. Brian's husband is a psychiatrist who we kindly have come on board to present during the mentoring sessions, but he's just added that they are putting people on metformin and it does help to reduce the weight gain and the metabolic sequelae. Someone has also said that Mounjaro is available in Australia and unfunded is $536 a month. That's Australian dollars. The
We'd
10
hope it'd be
milligram
fairly
dose.
similar.
Yeah,
And the best thing,
395 for the 4 milligram dose.
and the best thing we can get is competition.
Sorry, 5.
That's what's going to drive
Mm.
prices down.
And also just to add, so Northwest Pharmacy, which is mentioned in the Disability Allowance Guide, so they have a mission to provide the cheapest unfunded medications for New Zealand. They have no script fees and free delivery, so often that will make it cheaper than a lot of local pharmacies. Of course, a lot of these people, you want them to be utilising their local pharmacy to keep that continuity, but for those where it, is, hit and miss whether or not they could afford it, then that can be an option as well. And I think that's us. I hope that I got to all of the questions. Oh, we've got more messages coming through.
That's all right.
And I think we've got it all. So you can also send through questions, just like simple questions like what you've put into the Q&A, and we can answer them in the mentoring sessions as well. And especially if you're the sort of person that wants a little bit more time to think about your question, that's totally fine.
Thank you. It's a decent marathon effort.
Yeah,
To last
massive.
over an hour and a half. So thank you for joining. And we'll be here next Monday, same time, to talk about lifestyle management and some of our older glucose lowering therapies. So the
Wonderful.
next sessions will be a lot more targeted as we go along. But please feel free to ask questions that may not be related to what we're talking about in the webinar. And remember to use
Awesome.
multiple choice now. And thank you for joining. And thanks, Selija and Brian.
Thank you. Ka
Good night,
kite.
all. Ka kite.